So, I'm not Jason. It should have been Jason Stone who was giving the presentation today. He's the welfare officer that's based in Plymouth Hospital. But he's unwell, so we got me instead. So, the Defence Medical Welfare Service, there was a little video clip to just set the scene, but because we're on a tight timeline, I think there's a few other video clips within this presentation. I thought that probably wouldn't be beneficial. So the Defence Medical Welfare Service is a charity, has the MOD contract to support serving personnel. We deploy with the troops. It's been going 75 years. In my day when I was in the army, they were Red Cross girls, but since 1963 it's been the St John's and Red Cross Defence Medical Welfare Service. So we have welfare officers embedded at the QE here in Birmingham who are on military contract. We're in Cyprus, we're in Northern Ireland. But that, as you know, this period of austerity, the MOD footprint is reduced. And so our welfare footprint in terms of where serving personnel were has reduced as well. So we have, using Armed Forces Covenant money, the LIBOR funding, we have developed veteran services throughout the UK. And Jason is one of the welfare officers based in Plymouth Hospital who was put up for this award and was one of the finalists. So I'm just going to hopefully move on. So what we do, so we're an independent charity, as I said, in the medical pathway. So we're based in NHS trusts, largely, working alongside clinicians, and having that period of time that we can spend with patients that you as busy clinicians probably used to have but don't have so much time now. So we're able to sit with the patients, and it's all the armed forces community, so it's veterans and their families that we look after. And we've done a couple of point of provenance studies throughout the UK, Sheffield, Hull, Nottingham, down in Plymouth, Herefordshire, and we found around 40 to 50% of people within an NHS trust have got an armed forces connection. So it's quite a high proportion of your patients. And we work alongside the clinicians, picking up those social factors, those well-being factors that might be causing the patient not to be able to be discharged once they're medically fit. So we get very early on in the process and be able to help your bed flow, stopping that delayed transfer of care, hopefully. And I've got a couple of case studies which will illuminate that for you. But the other thing is also connecting them with those, supporting that patient and connecting them with those services outside of hospital that will prevent them from readmitting or for admitting for another reason. So that's largely on that. And it's also around the befriending of that individual, and a lot of these people perhaps are isolated, so it's preventing that social isolation and connecting them back into groups in their local community. This is a pathway, so in the hospital, Jason would have got a referral from any clinician, or even a self-referral from the patient, or even from a relative. He would go along, he would sit at the bedside, we'd have a conversation. During that conversation, building that rapport with that client, with that service user, may come up issues that he may be able to help with, and also address those things that I've just spoken about within an NHS trust. We would then, so we like the oil that oils the wheels. We've got all the connections in the community, and we're able to connect these people and affect those supported referrals. And we're not about giving a telephone number and saying, on you go, ring Veterans Gateway, ring SAFA, ring the RBL. It's about supporting that individual, empowering them. It's not de-skilling them. It's about empowering them, help them make that transition to connect with that group. And then once we have handed that baton on, it's about letting that patient run with that. And withdrawing our service if not required, because we know SAFA's picked them up. Poor Age UK, because I was particularly involved with Nottingham. We had a service in Nottingham, and it was for aged veterans, 65 and over, and we were based at QMC and City. And again, we did a lot of work with Age UK and work with them. So it isn't necessarily just all the military charities, but it's having those connections. So this is one gentleman down on the south. That project down there is for all armed forces. So you may not know, but there is only one unit in the UK where serving personnel go, and that is to the QE here in Birmingham, to the RCDM. So often these people who are serving are in your hospitals if they are injured in that location. So Alex was a Royal Engineer. He suffered a stroke on manoeuvres and was admitted, cardiovascular, into Southampton General Hospital. We have a welfare officer embedded in Southampton Hospital who worked with him, but because we're Jason in Plymouth, when this gentleman came back, when Alex came back to Devon, then Jason, we were able to make that transfer of care to Jason, and Jason supported Alex through. Supported Alex to engage with his physio, but also supported him to get to Stamford Hall and make sure that referral was made. And that is the Defence Recovery Centre, to improve his mobility and his speech and all those other things that go with a stroke of a young person. Another case that Jason was dealing with is a gentleman who was living with his family in Portugal, became very ill, Sydney. He was brought back to the UK, and Jason again met him when he was in hospital, and there was much confusion about what would happen to Sydney when he was discharged. So Jason was able, and they were going to discharge him into a care home, but there was a Royal British Legion care home not too far away, Dunkirk Memorial Hospital, and Jason was able to get him in there pretty quickly, which again impacted on that delayed transfer of care. It's just a little one. Sydney getting his certificate for reaching 100. And then a naval officer, or a naval veteran in the Merchant Navy, Caroline, her husband died, and again, we were supporting through that whole bereavement process and around her mental health issues that transpired from that. And you can see we work with a large number of organisations, and this is just to give you a flavour that we've got all those connections to help connect people to those specialities that will help them through their period of crisis. This is just a little day in the life of Jason.
It's Jason's first stop of the day. He's visiting former Royal Engineer Graham Stewart, who's at home recovering.
Hello, Graham. Good to see you, mate. Good to see you. Yeah, brilliant. It really is good to see you looking so well. Especially from the last time when I saw you in hospital.
Last year, Graham was diagnosed with an autoimmune disease. Doctors then discovered he also had esophageal cancer. It was in hospital that he first met Jason.
From Jason, from the welfare service, to obviously the RD&E staff, to my own family, to my friends. For me, I don't want to start crying at this stage, but they've all been there for me, and I can't thank them enough.
With the help of staff at the welfare service, were able to get Graham this recliner to help his recovery.
He was just coming in and out of hospital, taking up the bed, he didn't want to be in there. So I really tried to identify something that would keep him out of hospital and made sure that while supporting Mary, she was then able to look after Graham.
Next job is for Jason to see if there's any veterans on the wards at the Royal Devon and Exeter Hospital the service could support.
How are you? Yeah, good thing.
My name's Jason. I'm a welfare officer for the Defence Medical Welfare Service. And what our role is based here at the Royal Devon and Exeter Hospital to look at.
Having served in the Rifles himself, he has that extra connection with his patients.
I think for the younger patients that we have on the ward, just knowing there's somebody that understands what they're going through as well is really important. Having served in the military himself, knowing what works?
So the breakdown, this is Plymouth statistics, so 77% of those people that we looked after in Plymouth, this is, were veterans, and a very small percent, 5% were serving, and then 16% are serving families. And you can see on this other chart that 60% came from the emergency admissions. These are just some of the statistics, again, around work that we've looked after and help improving patients' welfare. And we improved, good or significant improvement over 50% of cases. And 90% of our onward referrals were to third sector organisations. So again, third sector doing the heavy lifting there, it's not statutory sector. So again, it's not a no cost, because charities cost money. Someone's got to either donate or whatever, but it is saving the statutory sector a significant amount of money. These are the locations in the south of England. As I mentioned, we have a project in Nottingham, or had a project in Nottingham, we're just about to reinstate it, fingers crossed. We're in Hereford, and we're based up, got a number of locations up in Scotland with Poppy Scotland as well. And this is the Armed Forces champion from Plymouth, who is really very positive about our work. And without him, actually, it's good to have the Armed Forces champion within an NHS hospital. It helps you get that message out and those referrals coming through. I'll just leave you with one last clip. One last thing, there's the Armed Forces Hospital Alliance, and there are a number of hospitals, there are 37 hospitals now that are signed up with the Veterans Hospital Alliance, and that number is growing in order to make people aware of the needs of veterans and serving personnel.
Brilliant, thank you very much.